Thank you, Dr. Krishna, and very good morning to all of you. I'm really happy that few more people have come in the audience than the judges and the presenters. The rules of today's presentation are: we will give you 6 minutes for presentation and couple of 2 more minutes for discussion. And if at all, and I leave it to the judges' discretion if at all there is something more to it. So, yeah, we will go in this order. We have one person, Dr. Manish, presenting two. So Dr. Manish will present his first paper first, followed by Dr. Dayala Sundaram, Dr. Hemalata, Dr. Deepa, and again Dr. Manish. So we'll start with Dr. Manish presenting the first paper.
I just want to tell you that on behalf of all of us, welcome you. There is the division of marks on the 4 aspects I want to make you aware. Number 1, the quality and the originality of the work, 10 minutes, 10 marks. The quality of presentation, 10 marks. Adherence to time is again 10 marks. And skill in discussion and defending your thesis is another 10 marks. And at the end of 5th minute, one of us will give a small signal that only 1 minute is left. And the questions will only be asked by 3 of us, just to be fair to the presenters. Now, may I now invite the first presenter? Are you ready? Krishna, Mahadevan, can we start now? Yeah. So the first presenter, as you just heard, is Dr. Manish.
Shall I start, sir?
Yes, please.
Okay. Good morning to all of you. Myself, Dr. Manish, Senior Resident, Department of Endocrine and Metabolism, LLRM Medical College, Meerut. Topic of my presentation is prognostic factor in patient hospitalized with diabetic ketoacidosis. Our main aim and objective to evaluate the patient, the various clinical and biochemical prognostic marker in diabetic ketoacidosis, and to correlate this various prognostic marker with mortality in diabetic ketoacidosis. The inclusion criteria: all diabetic ketoacidosis patients admitted in medicine or endocrine ward of our institution were enrolled for the study. Exclusion criteria: where the other we have excluded other hyperglycemic state like impaired glucose tolerance, stress hyperglycemia, other ketotic state like alcoholic ketosis, starvation ketosis, other metabolic acidotic state like lactic acidosis, hyperchloremic acidosis, uremic acidosis, drug-induced acidosis, and patient not giving consent. The patient were evaluated on the basis of history, examination both general and systemic. All the possible investigation which are required in a patient of diabetic ketoacidosis were done. The sample size were 270 patients hospitalized with diabetic ketoacidosis over a period of 1.5 years, were evaluated clinically and by possible laboratory analysis. They were managed with the standard way of intravenous insulin, intravenous fluid, and appropriate supportive care. Main outcome measure serial assay of serum electrolytes, glucose, blood pH, and clinical outcome of either discharge, home, or death. Final outcome of the patient: out of 270 patients, 189 patients were discharged, and rest 81 patients were expired. The result: in the demographic characteristic, the age of all patients ranged from 13 to 18 years with a mean of 38.99 and median of 39 years. We included both type of patient, type 1 as well as of type 2 diabetes mellitus. Among patients mostly below 14 years of age, constituent around 54.4% of population, and mostly are male, around 51%. In the result, the precipitating factor among patients mostly have sepsis. In sepsis, most have been pneumonia, urinary tract infection. Other precipitating factors are non-compliance to the insulin therapy as well as oral hypoglycemic agents. Other are acute pancreatitis, myocardial infarction, strokes, and other. These are the demographic characteristics. The final outcome was found not to be associated with the age. Incidence, however, the incidence was more favorable in case of lower age group. It is around 23.8% more favorable in age group less than 40 years of age as compared to the age more than 40 years. Favorable outcome was significantly different and higher in male as compared to the female. That means that male have more favorable prognosis as compared to the female. In the clinical characteristic, systolic and diastolic blood pressure at the presentation was a significant factor associated with the mortality. If patients have both lower systolic and diastolic blood pressure, they have higher chances of mortality as compared to the higher systolic and diastolic blood pressure. In the past history, we compare patient into following category: type 1 diabetes, history of type 1 diabetes, type 2 cerebrovascular accident, coronary artery disease, hypertension, and history of previous treatment. We can easily conclude from the table that the type 1 diabetes and type 2 diabetes were significantly associated with the poor favorable outcome, as while the other factor like CVA, CAD, hypertension, history of previous treatment does not follow any significance level. In the scoring level, we have done two scoring level. First is GCS and second is the Apache score. You can see easily in the table that the Apache score was significantly prognostic factor in case of diabetic ketoacidosis. If patient have a higher Apache score, then there is a dismal prognosis, that means higher chances of mortality. While the GCS score does not reach to the significant level. In the biochemical profile, all the possible parameters are done in patient of diabetic ketoacidosis, while some of the factors like blood urea, serum creatinine, magnesium, phosphate, anti-proBNP, SGOT, SGPT, and serum albumin were found significantly.
You have 2 minutes left. 2 minutes left.
Okay, sir. Were significantly associated with the final outcome or directly associated with the mortality. However, the increased serum lactate show a trend toward mortality but did not reach significance level. In the categorical analysis, we have done RBS, pH, bicarbonate level, TLC, lipase, and osmolarity. Only two factors, total leukocyte count, lesser the total leukocyte count, lesser the serum osmolarity, favor the prognosis. However, the more the total leukocyte count, more the serum osmolarity, dismiss the prognosis. However, the RBS, pH, bicarb level, and serum lipase level does not reach to the significant level. Predictor of final outcome, all the value which come out to be significant were further regressed by multivariate logistic analysis. It can it further revealed that the male gender have 7.93-fold higher favorable prognosis as compared to the female gender, while decrease in mean Apache 2 score and phosphate level were favorable outcome as compared to the higher level. Thank you, sir.
Thank you.
Yeah, I think good work. A couple of things. One, what were the differences between type 1 and type 2 DK patients? Because you had both the groups.
Sir,
Did you analyze that?
Yes, sir. Sir, because of the limited time availability in this.
But you can say, you can tell us.
Sir, type 1 diabetes has most favorable prognosis as compared to type 2 diabetes. Type 2 diabetes mostly came with us with a comorbid condition like hypertension, CVA, CAD. So they have a more dismal prognosis as compared to the type 1 diabetes.
Among other parameters, severity of ketoacidosis, other
Sir,
biochemical,
the
any difference or?
Yes, sir. So there is a difference. The newly diagnosed cases of type 1 diabetes has more favorable prognosis as compared to the previously diagnosed cases of diabetes mellitus.
Okay. Only other thing is, number seems to be very high for 1.5 years. Number you said 200 and
Sir,
almost 80. It's
it is
quite high.
It is a multi-scientific study. It is done in two centers. First is King George Medical College, Lucknow, when I was a senior resident. A second study was done when I was in LNRM Medical College, Meerut, when I was senior resident.
I have one question. You have categorized all these patients as diabetic ketoacidosis.
Yes.
Did you use a cutoff of the pH or bicarbonate or something to define that? Because you have a lot of type 2 diabetes in your group, many of which may show ketosis but not frank acidosis. So did you use a cutoff of a pH or bicarbonate?
Previously, we divided diabetic ketoacidosis into three types: mild, moderate, and severe. Previously, before when we mark a performer, after which all the patients which come into severe diabetic ketoacidosis were enrolled in the study.
I understand that, but what I'm asking is, when you say that all these type 2 diabetics were having diabetic
pH less than
ketoacidosis,
7.1.
did you use a cutoff below which you call them
7.1. pH is
diabetic
7.1.
ketoacidosis? 7.1?
1.
All right. Thank you.
I have one question to ask you. What is the normal mortality in a case of DKA,
Yes, sir.
and what does the mortality reflect?
Sir, the normal mortality is between 4 to 9% in normal Western literature. but in sub-Sahara Africa and the Hispanic America, now mortality is more, it is around 30 to 45%. The latest study done in Austria.
So from that point of view, how do you explain your mortality? 189 survived and about 11 plus 70, 80,
30%
80,
mortality.
30%. So it's on the higher side. How do you explain that?
Sir, we have taken all the patients which come with comorbidity also. Rest of the study which was done previously were done in cases of type 1 diabetes.
Okay, last question I want to ask you. You didn't mention about the protocol of care that was followed. Was it standardized between Meerut Hospital and the KGMC?
Yes, sir. It was.
And can you briefly tell us what are the highlights of the protocol? Any particular protocol you followed?
Pardon?
What is your protocol? Protocols of care, of decay?
Sir, patient we have treated in the standard way as per the BSPD guidelines by the intravenous IV fluid, if required, IV antibiotics, IV fluid, and supportive care. If patient require ICU admission, ICU.
Okay, thank you, Manish.
Okay, sir.
Just give us 1 minute. Thank you. A big hand for Manish.
Shall I start, sir? Good morning to all. I'm Dr. Dayala Sundaram from Department of Radiology, Apollo Specialty Hospital, Chennai. Our studies on role of acoustic radiation force impulse elastography in risk stratification of thyroid nodules. Elastography is a recent update in conventional ultrasound mode. The principle behind elastography is very much similar to the conventional palpation method. Malignant nodules, because of its high cellularity and heterogeneous architecture because of calcification and necrosis, they show little hardness compared to the benign counterpart. The same principle is used in elastography also. In real-time elastography, when we give compression with the ultrasound probe to the tissue, the soft portion of the tissue deforms more and the strain is depicted as red, whereas the hard component of the tissue deforms less and the strain is depicted as blue. Based upon the predominant color pattern, the nature of the nodule is assessed, whether it is hard or soft. But the disadvantage of this real-time elastography is it has some high operator dependency because we are giving some manual compression to the tissue. To avoid this, recently RF method is introduced. In this method, we have to keep the probe over the thyroid tissue and the compression is delivered by the probe itself. Electronically generated pushing pulse is sent from the probe and the nodule is excited. From the nodule, secondary shear waves are generated. This shear wave velocity is calculated and it depicts the elasticity of the particular nodule. The pushing pulse which is generated by the probe, it is called as acoustic radiation force impulse. In RF method, the elasticity of the nodule can be depicted by two modalities, various methods. One is virtual touch tissue quantification method, another one is virtual touch tissue imaging method. In VTQ method, the elasticity is depicted as it is depicted as a shear wave velocity. So it is a numerical value. And if the nodule is hard, the value will be more. If the nodule is soft, the value will be less. The other method is a BTI method in which there is a gray-white map will be generated. If the nodule is brighter than the comparative adjacent parenchyma, it is called as soft. If the nodule is, this is the nodule. If the nodule is equal to the adjacent parenchyma, it is considered to be equal stiffness. And this is the nodule here in the B mode. This is the elastogram image. If the nodule is darker than the adjacent parenchyma, it is considered to be hard. Important thing in our study is thyroid system. Like BIRAD system for breast imaging, thyroid system was introduced in 2009 to give a standard reporting system in thyroid ultrasound imaging. In this system, based on some 10 common findings, all the nodules can be categorized into 6 categories. Category 1 is normal thyroid, category 2 is benign findings, the malignancy risk is 0%, 3 is probably benign, the risk is less than 5%, 4A is undetermined, the risk is 5 to 10%, 4B is suspicious nodules and the risk is 10 to 80%, 5 is probably malignant nodules and the risk is 80%, whereas 6 is biopsy proven malignancies. The advantages to this thyroid system is it gives a uniform code between various specialty people for better patient management. The another advantage is it identifies the nodules in which we need FNAC or biopsy. Especially as the risk of malignancy is more in 4A, 4B and 5, we need intervention in this group of nodules. In our study, with our protocol, we included 79 patients. Out of the majority of them were female. Totally 130 nodules were included. In all patients, we did conventional B mode ultrasound, then Doppler, and the nodules were categorized according to the thyroid's category. And then we did VTI image, and the nodules were categorized accordingly, soft, equal stiffness, or hard. Then we did VTQ, and we obtained shear wave velocity for all the nodules. Finally, we did FNAC for all the patients, and the cytological results were correlated with these parameters. Out of the 130 nodules, 90% were benign, and 10% were malignant nodules. When we analyze the VTQ value, the mean VTQ value for benign nodules was 2.01 with the range of 1.46 meter per second, whereas mean VTQ for malignant nodules was 7.21 with a range of 1.63 meter per second. The cutoff value to differentiate between benign and malignant nodules were 3.55 meter per second. When we analyze the VTI images, most of the benign nodules were soft on the soft part, whereas the malignant nodules, the 12 out of 13 nodules were hard. Interestingly, most of the lymphocytic thyroiditis were equal stiffness. This is the distribution of nodules according to thyroid's category. When we analyze the concordance between the cytology as well as the imaging method, this is cytology, this one is ultrasound, this is RF methods. The concordance was almost similar for benign nodules in ultrasound, VTQ and VTI method, whereas the concordance was high in malignant nodules in RF, whereas it was low in ultrasound for malignant nodules. This is because most of the nodules which were categorized as undetermined or suspicious under category 4A and B were cytologically benign. This is very important because these three group of nodules will be targeted for FNAC or biopsy. When we decrease the false positivity in this group, we can decrease the number of unnecessary biopsies or FNACs. So when we see the breakup in our study, we had 17 nodules in suspicious category 4B. When we analyzed, only 4 nodules were found to be malignant. When we apply the RF values, almost 11 nodules in VTQ and 12 nodules in VTI were correctly downstaged by the RF method. In category 4A undetermined group, 7 nodules were identified in ultrasound. Out of that, only 1 was cytologically malignant. So in RF, almost 3 nodules downstaged by VTQ and 4 nodules were downstaged by VTI method. So to conclude, when we use RF method adjunct to ultrasound, we can downstage the undetermined group of false positive rate in the undetermined group of ultrasound category. Thereby, we can reduce the number of unnecessary FNAC or biopsy. Another advantage is when a patient presents with multiple nodules, we can choose a nodule with the help of RF to increase the diagnostic yield. Finally, we can use RF as adjunct method routinely to evaluate any thyroid nodules. Thank you, sir.
Thank you.
I just wanted to know whether you showed the concordance between the imaging and the other technique. Is there an advantage to the second technique?
Beyond FNAC.
Beyond FNAC. Like you have an FNAC of all the patients.
Yeah, yes.
You have done 2 elastography kind of techniques.
Two elastography techniques.
I want to know
and
whether...
I compared with the ultrasound also.
Did those 2 where there was concordance between the 2
Yeah, yes, ma'am.
radiology
Yes,
methods? So is it one better than the other? Are you saying that one is better than the other, or both? Any one of them will be sufficient to judge the hardness of the nodule?
Actually, both are equal in sensitivity and specificity, ma'am. But the VTI method has an edge over VTQ because in some of the nodules in lymphocytic thyroiditis, we had some higher values. But in VTQ, when we checked it with the VTI value, all the nodules showed some equal stiffness. So equal stiffness is more in favor of benign nature. So in that way, we can differentiate.
Did your correlation or evaluation done after the intervention, like surgery, whatever it is, and was there the concordance there?
No, sir. According to our protocol, we used to do, it's a prospective study. So first we have chosen only patients who came for FNAC for initial evaluation. But in between, we have a couple of cases in which total thyroidectomy done, and to check for recurrence, anything like that. But we found 2 nodules. Both of them had higher VTQ value. In that nodules, we can't do VTI method because VTI method we have to compare with the adjacent parenchyma. In those cases, VTI could not be done, but VTQ showed the higher values. It was proved with FNAC also.
And last question from my side: what are the caveats of elastography?
Yes, sir. It has its own limitations.
There are two caveats which are important.
One thing is in RF we can't do with cystic lesions. Completely cystic lesions we cannot evaluate because it produces some kind of artifacts. Another thing is in the recent machines they have some set of higher range. Like when we do for a particular nodule in papillary carcinoma, it produces some XXX value which could not be explained.
How many of these patients had these were single nodule or multiple also?
No, sir. If the patient presents with multiple nodule, we take at least maximum 3 nodules will be taken. So that 79 patients with 130 nodules were studied.
And then FNAC?
FNAC, most
because
of it.
Once you are doing ultrasound, you may be calculating elastography in one and FNAC is done in another nodule. Because it's not being done same time, FNAC?
It's the same time, same sitting. After doing elasto, we did FNAC also.
FNAC.
And each nodule was followed up individually. We marked it and we followed it individually.
Guided FNAC.
Yeah, ultrasound guided FNAC.
That's
ultrasound.
Good. Okay. Good.
Yes. Thank you, sir.
Dr. Hemalata.
A very good morning to everybody. I am Dr. Hemalata, first year postgraduate, doing MD Biochemistry from Sri Balaji Medical College. Our study is about biological clock, serum melatonin and hypertension. To introduce, melatonin is the endocrine product of pineal gland with circadian rhythm produced predominantly during nighttime. It synchronizes the day-night cycle through the photosignals received from retina. Hence, it acts as an internal clock predictive of solar time. This feature of melatonin satisfies it rightly to be called as biological clock. The graph depicts the day-night variation of circadian rhythm exhibited by melatonin. That is, it starts to rise after 8 p.m. and reaches the peak around 2 to 5 a.m. and again starts to declining in the early morning. This is the circadian rhythm exhibited by melatonin. The new era of melatonin research reveals its diverse functions, that is from aging to aggression, sleep to stress, reproduction to regulation of tissue, hibernation to hypertension. I now concentrate regarding the study of melatonin in relation to hypertension. Our aim is to study the significance of serum melatonin level in essential hypertensive patients compared with age and sex-matched healthy controls. A case control study is conducted at Sri Balaji Medical College and Hospital. Total number of people included in the study was 100, out of which 50 were essential hypertensives, 50 were healthy controls. It included 48 male and 52 female patients with the age ranging from 30 to 60 years. Blood is collected in a plain vacutainer for measuring serum melatonin level at around 4 a.m. under the dim light, since light has an inhibitory role towards melatonin. It is estimated by melatonin ELISA kit, which is a quantitative sandwich enzyme immunoassay technique. Serum melatonin level in hypertensive patients, the mean value was around 23.5 with controls 165.2. It clearly depicts that serum melatonin level were significantly low in hypertensives compared to healthy controls. The bar diagram also depicts the same result by decreased melatonin level in hypertensives. Melatonin synthesis from pineal gland is controlled by suprachiasmatic nucleus, which is the endocardian circadian pacemaker. Located in the hypothalamus of brain, it acts through specific receptors, that is transmembrane receptors MT1, MT2, located in the CNS and peripheral tissues and regulates the blood pressure. The renin-angiotensin system modulates melatonin secretion. Melatonin has an antagonizing effect over the angiotensin 2 along with increased nitric oxide release and reduced sympathetic output, together contributing for its antihypertensive effect. It's a potent free radical scavenger, potent antioxidant. It has a lipophilic nature, that is, it can cross the lipid cell membrane, so it can act as an intracellular antioxidant, contributing for reduced LDL levels. So it also has anti-lipidemic effect for its cardioprotective activity. Darkness usually stimulates melatonin secretion. Daylight inhibits melatonin. Therefore, the photosignals are received in retina and it reaches through the retinal hypothalamic tract, reaching the suprachiasmatic nucleus, and it stimulates pineal gland for producing melatonin. Melatonin, which has the circadian rhythm, has various pleiotropic effects, that is antioxidant, anti-inflammatory, anti-hypertensive, anti-thrombotic and anti-lipidemic effects. Therefore, all these features makes it melatonin to contribute for the cardioprotective role. To conclude, in our study, significant reduction of melatonin is observed in hypertensives when compared to normotensive patients. Our study is a small attempt to find the meaningful association of melatonin role in hypertension. Results are surely encouraging to undertake large-scale studies to establishing the definitive role of melatonin.
Okay, two questions. One, how did you decide that you are going to take sample at 4 a.m. only?
We have admitted the essential hypertensive patients with informed consent.
No, that's fine. Why 4 a.m. only? Why not 2?
Because the circadian rhythm of melatonin, the peak level of melatonin is between 2 and 5 a.m. So this value could be a reliable factor for...
Okay, second, any correlation with the complications of hypertension? And because you said it is... it's modulating antioxidant and it can prevent. It seems melatonin prevents complications. So, did you divide these patients in groups with complications?
I included all
so that
controlled and
analysis is not done.
uncontrolled. And probably the patients with more risk of uncontrolled hypertension signified more decrease in melatonin.
But you have done that analysis? Or
I have included everything, sir. I have not segregated.
Okay, that's very important. Yes. Because that's what you want to achieve. Thank you.
I've got a couple of questions. Now, the effect of hypertension or the melatonin hypertension correlation, you have given mediated to the RAS, renin-angiotensin system. Now, from that point of view, did you have any difference in the high volume hypertension or low volume hypertension?
I included
Was there a difference? Was there a difference with the RAS, this ACE level, or did you find difference in the two types?
I didn't evaluate the renin level or anything. No,
okay.
Sir. I evaluated only the serum melatonin hypertension alone. It needs further studies.
Fine. Does this melatonin level in the essential hypertensives that you took, does it depend upon the sleep pattern? Does it depend? Sir. So did you have any simple correlation of the lifestyle with the essential hypertension and the melatonin? Can you give any message from there?
Any night shift workers, continuous night shift workers who are exposed to bright light during night time showed decreased altered circadian rhythm and melatonin secretion.
But those data was not there. So can you tell us now what are the other data in relation, the correlation between the melatonin, lifestyle and hypertension, if you have? You may not have might not have presented, but you can tell us now.
But sleep has an irregular sleep or insomnia patients will have a reduced melatonin level, sir.
But did you show that in your study?
I have not included the stress and the sleep pattern.
So was not included. Yes. The last question is regarding the degree of hypertension, like mild, moderate, severe of the JNC7 or the two varieties in JNC8. Was there any differentiation between, you must have done JNC7. What was the different levels of melatonin with the degree of hypertension, mild, moderate, severe?
The severity, with severe, that is uncontrolled hypertension patient showed more reduced melatonin levels. So that's
came down. Yes, thank you.
childhood obesity, an observational study. The aims and objectives of our study were to determine the incidence of metabolic syndrome and its components among overweight and obese children, to compare the incidence of metabolic syndrome using two different definitions with the impaired fasting glucose level, metabolic homeostasis model assessment of insulin resistance of 2.5 or higher to define the glucose regulation component. It was an observational study conducted at Kasturba Hospital, Manipal, approved by the Institutional Ethics Committee, conducted between October 2012 and June 2014. The study participants included 68 overweight and obese children between 10 to 18 years attending pediatrics outpatient department. The main outcome measures were relative risk of individual metabolic syndrome components, that is central adiposity, hypertriglyceridemia, low Figure 1 showing the age distribution of study participants. 67.64%, that is 46 out of 68 children in the study, were in the age group 10 to 13 years. 72.06%, that is 49 out of 68 subjects, were obese males. The proportion of obesity was 69.57%, that is 32 out of 46 in males, and 77.27% in females, which was comparable. Figure 2 showing the distribution of metabolic syndrome components among study participants. Central adiposity was the most commonly observed abnormality in the obese group, followed by HOMA-IR of more than or equal to 2.5. While in the overweight group, elevated HOMA-IR was the most common. All except one in the obese group, that is 97.96%, had central adiposity, as against 57.89% in the overweight group, which was statistically significant, with a p-value of less than 0.001. Impaired fasting glucose was the least commonly observed abnormality in both the overweight and obese groups. Only 14.71%, that is 10 out of 68 of the participants, had an impaired fasting glucose, whereas 79.41%, that is 54 out of 68 of participants, had a HOMA-IR of more than or equal to 2.5. Impaired fasting glucose was present much less frequently than elevated HOMA-IR. Majority in the study group were normotensive. Elevated blood pressure was seen in 34.69%, that is 14 out of 49 of obese children, and 31.58%, that is 6 out of 19 overweight children. Hypertension was seen in 3 out of 6 overweight children with elevated blood pressure, and 10 out of 17 obese children with elevated blood pressure. The relative risk of central adiposity was 28 times more if one was obese than overweight. The relative risk of other metabolic syndrome components was comparable across the overweight and obese groups. The female gender had a 2.5 times relative risk of developing metabolic syndrome defined by elevated HOMA-IR. 26.47%, that is 18 out of 68 of the participants in our sample, met the criteria for metabolic syndrome using an IFG level of 100 mg per deciliter or higher, and 48.53%, that is 33 out of 68, met the criteria using a HOMA-IR of 2.5 or higher. Our conclusion: the mean decimal age of the study participants was 12.64 years. The proportion of obesity was 69.57% in males and 77.27% in females, which was comparable. The difference in proportion of central adiposity across the overweight and obese groups was statistically significant. The incidence of metabolic syndrome increased with BMI. Girls had a higher rate of metabolic syndrome than boys. Metabolic syndrome HOMA consistently identified more participants with metabolic syndrome than metabolic syndrome IFG and was a valuable catalyst for an early intensive diet and exercise intervention targeted at preventing further disease progression. Thank you.
I have just one question. How did you define, this is a younger age group, how did you define overweight and obesity?
Madam, I have used the WHO charts with the centiles, BMI centiles. So the weight cutoff with more than 85th centile but below the 90th centile were taken as overweight children, and obese were above the 90th centile.
Waist.
A waist circumference,
Waist,
only the waist
yes.
circumference.
So that's done now. So what is the correlation between the triglyceride and the waist circumference?
I did not get a positive correlation, but definitely elevated triglyceride levels were associated with increased BMI and increased central adiposity, waist circumference.
Last question.
But it was comparable among both overweight and obese.
Beyond HOMA IR, from the available data, do you have could have calculated any other index of IR? What is the other index IR that you can calculate from these values of fasting, insulin and glucose?
So other indices are available. The names exactly I do not remember, but they are there.
Your result show that TG were higher in obese compared to higher in overweight compared to obese. Why so? Any explanation? On the other hand, you are saying it is correlated with BMI, so yes. You are making contradictory statements.
Sir, I did not get this positive correlation that increasing central adiposity and elevated triglyceride levels also. So probably the other data that I have collected, even in the form of questionnaire from the children, that the kind of oil that they have used for cooking and other diet and exercise patterns that they are following. So probably it may not be directly associated with central adiposity, but there could be some relation with their dietary habits and the kind of oil that they are using, that they have central adiposity with triglycerides.
Good morning to all of you. Myself, Dr. Manish, Senior Resident, Department of Endocrine and Metabolism, LLRM Medical College, Meerut. My topic is incidence of adrenal insufficiency and relation to mortality in patients with septic shock. My aim and objective to determine the incidence of adrenal insufficiency and in relation to mortality in patients with septic shock. Patient with septic shock admitted to the medical ICU of our institution in between July 2012 to June 2013 were studies. The diagnosis of septic shock was made in accordance with the criteria proposed by Survival Sepsis Guidelines 2010 and American College of Chest Physicians. Two criteria were used to make the diagnosis of adrenal insufficiency. First is the absolute adrenal insufficiency, in which the basal serum cortisol is less than 20 microgram per DL and increment of less than 9 microgram DL after the ACTH stimulation test. And the relative adrenal insufficiency in a patient with baseline cortisol of less than 20 microgram per DL and increment of less than 9, more than 20 and the less than 9 after the ACTH stimulation test. All patients had their serum cortisol measured at the time of admission and 1 hour after giving 250 microgram of ACTH. Then hydrocortisone 50 milligram IV every 6 hourly was started and it was continued for 7 days or less according to the hemodynamic response in a patient who were found to have adrenal insufficiency. In those patients who did not have adrenal insufficiency, hydrocortisone was discontinued on the next day. The Apache 2 score was used to monitor the progress of the critical illness of the patient. Apache 2 score was evaluated at the time of admission and patients were categorized into the 3 categories. First with score less than 10, second with score between 10 to 25, and third with score more than 25. Mortality rate at the end of 28 days after hospitalization was compared between the patient with AI and two patients without AI. Total of 100 patients were enrolled in the study. During the study period, the written informed consent was taken prior to the study. The result, in the demographic profile, out of 100 admitted patients, male were 42, female were 58. Adrenal insufficiency was found in 42% of patients, absolute AI in 14 patients, relative AI in 28 patients. AI was found to be more common in female population as compared to the male, and it found to be statistically significant. In our study, 50% of patients with relative AI were found between the age group of 21 to 40 years age, and 72% of absolute AI were found in the age group of 41 to 60 years. That means that absolute AI is more in advanced age, and it is also found to be statistically significant. Distribution of adrenal insufficiency according to the etiology of sepsis. The lung pathology is the most common etiology associated with the adrenal insufficiency, followed by a central nervous system infection, followed by the urinary tract infection. The maximum number of patients had Apache 2 score in between 10 to 25. In 28 patients, Apache 2 score was found to be more than 25, and in 72 patients, it was less than 25. It is also found to be statistically significant as to follow the prognosis. The mean serum cortisol value of the first measurement at the time of admission was found to be 29.6 plus minus 17.7 microgram per dl, and second, after 1 hour of giving 250 microgram of synectin, it was found to be 36.75 plus minus 17. At the time of admission, the baseline serum cortisol value of less than 10 microgram dl was found in 8 patients, and all of them expired. Absolute AI were seen more commonly when Apache score was greater than 25, where most of the patients with relative AI had Apache score in between 10 to 25. The total mortality rate was found to be 48%, and was significantly higher in patients with AI than in those without AI. However, the mortality rate was not significantly varied between the absolute and the relative AI. The patient with absolute AI had higher likelihood of mortality than non-AI, but the trend of relative AI was not significant. Apache 2 score of greater than 25 carried a higher mortality rate than a score of less than 25. In the survival group, the requirement of inotrope support for the day was in the order of non-AI has minimum requirement, while the relative AI has higher requirement as compared to the absolute AI. Conclusion, patient with AI required vasopressor support for a longer time than the patient without an AI. Only patient with AI, absolute as well as the relative, show positive response to the steroid therapy, while in patient without an AI show no survival benefit. The study has one important limitation, it is comprised of a small number of subjects. We would like to conclude that AI was prevalent among patients with septic shock, and it lead to the prolonged duration of shock, prolonged requirement of vasopressor. We would like to recommend evaluating adrenal status in a patient with septic shock because it would entail prognosis. Thank you.
Good presentation, but I'm surprised at the high number of patients who had absolute adrenal insufficiency. Did you measure any other parameters to see whether this could be a change that happens because of changes in the binding globulin, albumin, and other factors? The low values of cortisol that you had, could it be a reflection of an abnormal binding of cortisol in the serum, which can happen in various sicknesses?
Ma'am, we have all the parameters like... Ma'am, we did all the serum albumin, globulin, all the hematological parameters, and we also collate this finding with the adrenal insufficiency. It found to be non-significant.
How about the patients who survived? Did you look at them again to see whether they had previously existing adrenal insufficiency? Was it something that transiently developed during the period of sickness, and was it more serious in patients who had more severe illness? Could it be a reflection of a more severe illness?
We compared mortality at day 28 of the date of admission. 28 day पे मैं mortality calculate किए. During the ICU stay, we just go to see the absolute and the relative adrenal insufficiency.
How many patients recovered?
Ma'am, our main aim was to calculate the mortality at the 28th date of the admission. And that's
So how many?
28th day पे मैम calculate किया उसके बाद कभी. We never follow the patient. We never follow the patient.
Two is one dose of hydrocortisone used, I think, on the lower side. You used only 50 milligrams every 6 hours.
जी. This is according to the survival sepsis guidelines which was proposed in 2010 and the American Chest Physician guidelines which was proposed in 2011.
Yeah, maybe, but for the Indian population you need, and the lowest dose is at least 10 milligrams per hour. Second was, did you look at the etiology of adrenal insufficiency in this patient?
Sir, we did not go for the molecular analysis, but we have...
No, simple CT abdomen for adrenal glands would have given a lot of information.
Sir.
No, okay.
Did you find the correlation with the degree of sepsis and the AI?
Sir, according to, in our study, the lung pathology is the most common cause for the severe sepsis, followed by a central nervous system. In other study, in the French and the Corticus triad, in Corticus triad, the intra-abdominal sepsis was the most common etiology associated with the severe sepsis, while in the French trial, it was a lung pathology, which is most commonly associated with the sepsis.
Did you find any other correlation between the SARS and the AI? Any other systemic inflammatory response with the AI, either absolute value or the synaptic?
Sir, we, one testing finding that we can conclude from the study, the surgical ICU patient which land up into the adrenal insufficiency has higher mortality as compared to the medical ICU patients.
Dear friends, I must mention here that all the 6 papers presented, the 5 papers presented were absolutely fabulous, and me and my colleagues have liked those presentations, and it is a matter of competition and judgment, and so one will be ranking the papers. Yes, we will be announcing the results only in the valedictory function, and but I just am here to say that we have liked all the presentations, and it was great to listen to this wonderful work done by all the investigators. A big hand for all of you, and the winner has to be one, but the participation of all of you have been excellent. Thank you. Thank you very much.